Hello everyone, welcome to the Kernel series. Today let us talk about nausea and vomiting in pregnancy. As you all know, nausea and vomiting is quite common presentation in pregnancy. Yes, as high as 80% of the people in pregnancy has the symptoms of nausea and vomiting. But it need not be severe all the time. Okay, so there is a difference between emesis and hyperemesis gravidarum. So before going into that, let us know what are the different causes of emesis or vomiting in pregnancy. First of all, in pregnancy per se, in early pregnancy and late pregnancy. Early pregnancy, it can be either simple vomiting, that is emesis gravidarum, which patient presents as morning sickness, or it can be hyperemesis gravidarum, which we will discuss in detail. And in late pregnancy, it can be either due to reappearance of the early symptoms, or it can be continuation of the early symptoms per se. Some patients has throughout the pregnancy. Next, it can be either due to preeclampsia. Minded, preeclampsia is very important cause to rule out in late pregnancy when a patient presents with nausea and vomiting. Okay, and coming to other associated with pregnancy like medical causes, maybe infections like urinary tract infections, infestations of worms or hepatitis, ketoacidosis. These are the medical complications. Coming to surgical complications, most common is appendicitis, pancreatitis, cholecystitis, and these are the surgical complications. Coming to gynecological conditions, yes, like in cases of ovarian torsion or red degeneration of fibroid, also patients presents with complaints of pain abdomen, nausea and vomiting sensation. Now, let us discuss about hyperemesis gravidarum. Hyperemesis is a very important 3-marker and your MCQs questions. So, let us see what hyperemesis by definition is. It is excessive or severe vomiting which adversely affects the health of the mother and also incapacitates her to do her day-to-day activities. But remember, some patients with one episode of vomiting can come to you saying it is very severe, and some patient even with so much vomiting stay at home to develop complications. So how will you diagnose them? That is by using this triad. Firstly, if they have weight loss of more than 5% to her pre-pregnancy weight, and secondly by dehydration, and thirdly by electrolyte imbalance. These are the 3 signs of hyperemesis gravidarum, and also some adverse effects may be there like ketoacidosis or alkalosis due to excessive chloride loss in the vomiting. Now, coming to the incidence of hyperemesis gravidarum, it is drastically reduced these days. It is as rare as 1 in 1000 pregnancies. But remember, emesis gravidarum is quite common, that is around 80% till now. But hyperemesis is reduced drastically, 1 in 1000 pregnancies. This is because of firstly, the better family planning methods and acceptance of family planning methods that reduced unwanted pregnancies. Secondly, due to better antenatal clinic, early visits to the antenatal clinic, and thirdly, good antiemetics and antihistamines available these days. That makes a better treatment for emesis and prevents development of hyperemesis gravidarum. Okay, that is why it is quite important to know that incidence is drastically reduced. Next, coming to high risk factors. What are the high risk factors for developing hyperemesis gravidarum? Yes, firstly, per se, hyperemesis is quite common in primigravida. Yes, first pregnancy per se is a high risk factor, and following which, if in first pregnancy she developed hyperemesis, she has very much high likely to develop hyperemesis in her further pregnancies. And secondly, if there is a family history of hyperemesis gravidarum, then also there is high chance of developing hyperemesis gravidarum for her in this pregnancy. And multiple pregnancy or twin gestation where there is increased beta HCG and direct association with vomiting has more chance of developing hyperemesis. And also hydatiform mole, molar pregnancy has high chance of developing hyperemesis again because of increased beta HCG levels. Okay, these are the high risk factors for developing hyperemesis. Now coming to the different theories for hyperemesis gravidarum. Firstly, the hormonal theory. Yes, the beta HCG has direct relation with the vomiting. As you all know, beta HCG starts raising from early pregnancy, peaks around 9 to 12 weeks, and then gradually maintains till 20 weeks, and after that it starts reducing. The same pattern is followed in hyperemesis also. It starts in a early pregnancy, 9 to 12 weeks it peaks and then maintains till 20 weeks, and then it gradually reduces. Hence beta HCG is directly related to hyperemesis gravidarum. Secondly, also increased estrogen is a different hormonal theory, and increased progesterone. Yes, why? Due to progesterone. Progesterone is a relaxant that causes smooth muscle relaxation. Your sphincters get relaxed, hence there is easy chance of regurgitation and vomiting. That is why increased progesterone has high chance of developing excessive vomiting. Coming to the next theory, that is psychogenic theory. Psychogenic theory is where once the patient starts having this feel of nausea, vomiting, it persists for a longer time. Hence, it can get converted into hyperemesis. Secondly, the change of place, the psychology, this change of place. For example, with the same treatment at home, she might not be better, but with the same treatment at a hospital, she is feeling better. And also in their in-laws' house, or they have more chance of developing hyperemesis. But if the change of place to maternal house, then there is very much chance to reduce hyperemesis and better treatment at the home itself. So that is why hyperemesis is directly related to the psychological factors also. And thirdly, coming to the dietary factors, the starvation, the carbohydrate reduction or the starvation has high chance. That is why morning sickness or early morning symptoms are quite high, because overnight starvation and depletion of carbohydrate is very high. You should also know pregnancy is a state of fasting hypoglycemia and postprandial hyperglycemia. That is why the increased starvation duration, there is more chance of vomiting. Okay, dietary factors. And also because of vomiting, they develop B12 deficiency and other multivitamin deficiencies also. Now let us see what are the clinical features that the patient presents with. The early features are like excessive vomiting or nausea sensation, inability to eat food. These are the early features. Next, coming to the late features. Late features are like this. Like for example, the vomiting is very severe, there is so much starvation, inability to do her day-to-day activities, and there may be decreased urine output, loss of weight, consciousness. All these symptoms starts producing in the late symptoms. Next, coming to the signs. As you know, dehydration is one of the feature in the triad to diagnose hyperemesis. So how will you diagnose dehydration? Yes, firstly, shrunken eyes, dehydrated look, dry coated tongue, acetone smell in the breath, hypotension, tachycardia, raise in temperature, oliguria. These are the different signs of dehydration. And coming to the weight loss, there will be reduction in the weight. These are the different signs by which you can know that she is developing hyperemesis gravidarum. And next you will go for investigations in which you can find electrolyte imbalance, hyponatremia, hypokalemia, hypocalcemia. All this reduction in the electrolytes can cause electrolyte imbalance, loss of consciousness, develop complications. Okay, and also you should do her urine analysis. This is the first test that you will do, because by using a dipstick, it is a faster and OPD based to know whether she has developed acetone in her urine, that is ketoacidosis. If the ketone bodies are positive in her urine, then it is a sign of severe dehydration. Other investigations that you have to do is like CBC, where you can see raised hematocrit due to decreased intracellular volume. You should do her LFT to know if the LFT or the liver function test is deranged. You should see her thyroid profile, because they are more prone to have hyperthyroidism kind of feature. And you should also look for her ophthalmoscopic examination to see if there is any retinal detachment because of excessive vomiting and retching. Okay, and if it is too severe, you may have to do endoscopy to see if there is any esophageal tears. These are the different complications. Based on the presentation, you will do the investigations. Next, coming to complications. As you know, there are so many maternal complications because of hyperemesis. Firstly, the neurological complications like Wernicke's encephalopathy, beriberi, pontine myelonolysis, and they can go into depression, they can have Korsakoff psychosis. peripheral neuritis. These are the different neurological complications. Others like esophageal tears, stress ulcers in stomach, jaundice, convulsions, coma. These are the other complications that you can see in hyperemesis gravidarum, mostly maternal complication. Coming to the fetus, fetus is most likely unaffected and they can have more chance of small for gestational babies or preterm deliveries. These are the different fetal complications. Next, before going into treatment, let us see how to prevent it. So if a patient presents with MSS gravidarum, you should give her certain advice for her so that she doesn't develop hyperemesis. So what is this? You should advise her to take frequent meals, not once a large quantity but frequent meals, and ask her to take fluids or liquids in between meals, not after meals. She should not drink water after meals but in between meals, and she should not lie down immediately after food, and she should have a sufficient amount of walking and exercise, and she should avoid gastric irritant foods and nausea triggering foods. High fat foods should be avoided. Next, coming to management. Firstly, what are the principles of management? You have to correct her dehydration, correct her electrolyte imbalance and stabilize the patient. Then give her antiemetics and then ask her to take oral fluids or liquids once she is stabilized. So what are the different antiemetics? There is a first line, second line and third line of drugs given in hyperemesis. First line of drugs are cyclizine, prochlorpromazine. These are the first line drugs. But in hyperemesis, mostly second line drugs work, that is your domperidone and ondansetron. Next, coming to the management with different antiemetics, that is, firstly, first line drugs are prochlorperazine, chlorperazine, and second line drugs are metoclopramide, domperidone, ondansetrons, and third line drugs, when it is not treated with these, you can give her steroids and phenergan for further prevention of complications. These are the different drugs. As shown, it is first line, second line and third line. Very important, you should remember them. Finally, before concluding, how will you know that the patient is better or stable? That is, there is reduction in symptoms of nausea and vomiting, patient looks better and she starts feeling hungry, urine output becomes normal, electrolyte imbalance becomes normal, and she starts to do her day-to-day activities. These are the signs and symptoms saying that she is better from her hyperemesis gravidarum. Thank you for watching this session. Have a great day.